thank you, Dato Silva, for that very kind introduction. It was exaggeration of too many things, but I'm actually from Malaysia. I'm from Ipoh. And I left for Singapore when I was very young, now 25 years ago. But I still come very often. My parents are still here, and my sister just lives down in Jalan Gasing. So I'm very happy to be here to see that so many of you are supportive of the prostate cancer survivors. Some of you may be relatives of prostate cancer patients. In Singapore, we don't have a specific group for prostate cancer like a society. In fact, most cancer groups come under the Singapore Cancer Society. So they are our biggest survival group. But within that group, we have a group of prostate cancer patients or survivors who actively take part in activities, and they call themselves the Walnut Warriors. So that's our prostate cancer support group. And I think they're very active, they're very vigorous as well. In fact, we have an exercise program for them. Every week they come, they get a trainer at our rehab center. So we have a rehab center specific for cancer survivors. There's a gym, there's also a kitchen for survivors to cook, and a library and things like that. So the prostate cancer survivors, the Walnut Warriors are very, very active, and I'm glad to see that it's just as good here as well in Malaysia. So I was given this topic of talking to you about the final stage of prostate cancer. I think earlier the talk given by both Mr. Rohan and Mr. Murali were excellent. In fact, Mr. Murali's slides were very, very good. Later I must ask him permission to couple the slides from him for my future talks. But I think he very simply put through to you what prostate cancer is, especially when it recurs. So in the very early stage, the recurrence is, as he mentioned, with just the PSA rising. Then, of course, later on, we will find that disease has spread to other parts of the body, and we can actually see it on scans, using some of the many scans that were mentioned just now. So I will try to tell you what are the drugs available. A lot of times when patients get stage 4 cancer, they always think it's a death sentence because the treatment intent is no more cure. Stage 4 cancer in general cannot be cured. So it's the final stage. And very often the thing that people do most of the time is they'll call up a friend with cancer who will tell them, oh, stage 4, say, die like 6 months or something. It actually depends, because that friend's information or relative or whoever has it may have had more aggressive cancers like pancreatic, lung cancer, those kind of cancers, liver cancers. In those cancers, stage 4 survival is still very poor. It's about 6 months, so it's true. But with prostate cancer stage 4, for those especially who are hormone sensitive, I think now you're familiar with the terms hormonal therapy and all that. So in the early stages, you'll be hormonal sensitive. So if you're hormonal sensitive, you can actually live very long. On average, anywhere between 3 to 8 years. So it's not 6 months. So with prostate cancer, it's different. In fact, the reason why a lot of people eventually die from, they don't die from cancer, but they actually die from other causes, competing causes. Because once you hit 70 years old, there are so many diseases that are waiting to kill you. They're all trying to fight to kill you. There's heart attack, there's stroke, there's so many diseases, they just want to kill you. And you may coincidentally have prostate cancer at the same time. It's important to treat the prostate cancer, but don't neglect the rest, you see, because they will likely kill you faster. So sometimes I tell some of my friends the reason why oncologists even have a job is because of the cardiologist. Because now care for heart attacks are so good, especially with the newer medication and their better technology with stents. They make patients live long enough to get cancer. Because cancer is a disease of aging. Like prostate cancer is a classic example. By the time you're 70 years old, 60% of people out there already have prostate cancer, but they don't know. Right? And it wouldn't have bothered them not knowing at all, because 4 or 5 years later, if you go by average lifespans, they might have died from heart attack. So that's why that's one information I got to talk to you about in relation to stages and why stage 4 is not a death sentence, and you shouldn't get upset and depressed. Upset, yes, but after that you just got to get control. And I think for you to be here today, you are the guys who want to take control of your disease. make sure you know what are the latest things available and do the best you can to keep yourself fighting. All right? So I'm here to provide you some information about what are those weapons available. At the end, the war or battle that you have with cancer is a personal one. You know, different people have different ways of, you know, going about this battle. But as physicians, we can help you through this by providing you with tools. So these medications are like tools. You know, some are good, some are not so good. Overall, all of them will have side effects. It's a fact. There's no one medicine that will never have a side effect. But it's important to know what they are, and then you may find you get some benefit from them. The reason I tell you this is because even as physicians, we compete with TCM practitioners and traditional health practitioners. So there's a lot of belief that these things work. If you tell a doctor or a scientist about how these things work, we'll just laugh it off. We'll laugh at you also, because scientifically it doesn't make sense. But sometimes faith alone may help you through it. You know, maybe the placebo effect of faith. I think these things can be used in combination. I think we don't know enough about traditional medicine to just brush it off. But we also don't know enough to purely have faith in it to use it. So what I'm trying to tell you is don't I rule out, you know, the Western medicine because there are side effects. Because if you think about it, like prostate cancer, we use a drug. Later I'll show you, chemotherapy. It's actually from the bark of a tree. You know, it's from nature. A lot of people think if you go and get medicine, because stage 4 cancer, people have given up hope. So they say, why not try TCM? You know, because it's natural. It's from the roots, it's from the tree. But a lot of our chemotherapies are from nature. They are from the trees, from the plankton in the sea. So they're all very natural products. Of course, now we make it synthetically. So that's something I find difficult talking to patients about, because they are, like my patients, the General Hospital in Singapore where the cancer center is very near Chinatown. It's next door. So after they see me, they walk down the road and see the Chinese insane. Sure, and guaranteed. So I have to tell them, you know, what are the pros and cons of doing that. Because sometimes their medicine may interact with mine. And the misconception is their medicine is safe because natural, and the Western medicine is dangerous. But which is not true, because even our Western medicines are from natural sources, except now we make it synthetically. So this is just to clear up some misconceptions. I hope my slides won't be too technical, but later on you can ask me questions if you're not very clear about some of the drugs. So this is the place where I work right now. It's a very complicated slide, but basically these are all the drugs that have been approved for treatment up to date. So I think earlier the speakers have already showed you what which stages these patients can be in when they have cancer that has spread. Initially, when it's localized, they may have PSA relapse. And Mr. Murali mentioned to you about ADT, that's androgen deprivation therapy, or the hormonal therapy. Then after that, they become castrate resistant. Hormones don't work, so they become resistant to the hormones. And then we have all these drugs. Each of these has been tested very rigorously in what they call phase 3 clinical trials. So they're very rigorously tested, billions of dollars spent, which is why the cost is then transferred to you, which is why all these drugs are very, very expensive. Then what is new in the last few years is a drug called enzalutamide and abiraterone. These two are hormonal drugs. They're oral therapies. This is chemo, which has been there for the past 12 years. It's been approved in prostate cancer. There are two chemos that are approved, which is this drug here, docetaxel and cabazitaxel. And that's the hormonal drug. And now what has changed in the last year, 1 year, is that we are using hormones even in the earlier stage where you're hormone sensitive. Last time using chemo at hormone sensitive stage. Last time chemo was only used when hormones don't work, or they call them castrate resistant. But now you can use chemo even in when you're sensitive to hormones, and they found that you can live substantially longer. In fact, the study that they did showed that you can live up to 1.5 years longer than patients who take chemo, who don't use chemo early. So this, again, a very, very busy slide. I want you to ignore all these numbers. These numbers are there just to show you that these drugs have been rigorously tested and they work. But basically, these are all the approved drugs which you saw on the pictorial one slide ago. And these are the hormonal drugs. Sipuleucel T is a form of immunotherapy. It's actually cancer cells or antigens taken from your body. They go and process it and they develop antibodies and they put it back into your body. It's a dendritic cell vaccine. So they actually transfuse back into your body and your body uses those cells to kill the cancer cells. Unfortunately, although it's approved in the United States, the company that made it went bankrupt because not many people used it. It cost $120,000 US for 3 injections. So that's the thing about stage 4 of any cancer is the biggest toxicity is financial toxicity. More than the diarrhea, the hair loss and all. You actually lose everything, even the clothes on your body, because you have to sell it to pay for the cancer drugs. So sometimes you must think rationally as to, is it worth it to spend so much if the benefit is not much? So you need to know what the benefit is before you commit, right? Because these drugs are not going to cure you, but they can prolong your life. But is it something that you are willing to spend so much money for, you see? So it's something to consider when you choose these drugs. Later I'll talk to you a bit about the cost, but not so relevant here. Now, one more drug that's not available in Malaysia, we have it in Singapore, and now I think about 4 countries in Asia have, is this one called radium-223. So radium-223, if you all recall many years ago in your chemistry, the periodic table of all those chemicals in chemistry, so radium is in the same group as calcium. So the body is not very clever in differentiating these two things. So we give radium because the bones where all these cancer cells are, these metastatic cancer cells are, will take it up thinking it's calcium, and it goes in and it kills. It's like a Trojan horse. It thinks like, this is calcium, so it goes in and it kills those cancer cells. But this only works when the cancer has spread to the bone alone. It doesn't work when cancer has spread to the lymph nodes, the lung, or other areas of the body. So only works when it's to the bone alone. Then there's other chemo drugs here, cabazitaxel, and the hormonal drugs. Right? So these are all the approved drugs. Okay, I've closed that sipuleucel because it's not available, and of course radium-223 is not available in Malaysia as well. So I will then go on to tell you what's new in the last few years, including a repeat of what I mentioned just now. Remember I told you about chemotherapy for the hormone-sensitive patients? So let's say you have stage 4 cancer with a lot of cancer disease. That means you've got more than 4 spots in different parts of the bone, or your cancer has gone to the liver or lung, that is called viscera, or organs, important organs in your body. Then the advice now is you should get chemo early, right? But to a lot of people that is a big shock, because chemo everybody associates with terrible side effects, some of which are true. But you see the benefit for someone who takes chemo early stage versus someone who doesn't, 17 months extra survival. That's about 1.5 years. So if you choose to take chemo early when you fit the profile of a patient who should get chemo at that point, you can add another 1.5 years of survival. To put things in perspective, a lot of new cancer drugs nowadays are approved, like for lung cancer or for breast or pancreatic cancer or GI cancers. They get approved because their survival benefit is about 3 or 4 months more than the old drug. And they get approved because it still prolongs life. But this is 1.5 years, so it's substantially more. So it's something to think about if you're having prostate cancer and you're still hormone sensitive in the very early stages of advanced prostate cancer. But there are a lot of challenges in chemo use. I mean, people hear chemo in Mandarin over there as pa liao. It's the worst word ever. It's like worse than the worst 4-letter word, right? They hate it because every time you think of chemo, you look at when you watch TV, a program or some show, always the person has lost all their hair, and they're always bloated, and they're always next to a drip machine, and they can't leave their homes, and sometimes you even think of it as worse than having the disease itself, right? But I think you must have some faith that your doctors will want to choose treatments that they feel in balance, and I think earlier Mr. Murli showed a nice picture of the balance, the Dutching with the stones and all, right? It's all about a balance. Now no therapy has 0 side effects. So if the benefits outweigh the side effects, then you should consider it. And normally when the oncologist talks to a patient, we will tell you what is the estimated number of cycles. Chemo go by cycles. Every 3 weeks we give 1 injection. So the oncologist may say 6 cycles. Straight away they'll get shocked. how long will it take? 4.5 months, just 18 weeks. But don't think about it as 6 cycles at first. Think about it as 1 cycle at a time. We don't know whether you will respond. We don't know what the side effects you're going to get, and everyone is different. Some patients, the side effects, no problem. Some patients, very, very bad side effects. And we don't know who's going to get bad side effects, who's not going to get side effects. The only way to do it is to try 1 cycle. So patients are averse to it because of side effects. QOL is quality of life. So a lot depends on what we define as, or you define as your quality of life. Basically, if you are retired, your quality of life includes, taking care of your grandchildren, which many of you have to sometimes. I don't know whether that improves or worsens your quality of life. Initially, maybe it improves, and later it worsens. Then other things, you may like to play golf, or you like to do a certain hobby, you like to travel. So all that are parts of your quality of life. At the most basic level will be your activities of daily living. Brush your teeth, take care of yourself, to be independent. You don't want to depend on someone else, right? So when we talk about quality of life, worsening or depreciation is when a person can't do those things. What they used to be able to do, they can't do, right? So these drugs, do they affect the quality of life? The answer is yes. But the extent in which it affects, we don't know, we can't predict. Some patients, not so bad. They still are able to do all the activities. But at the bare minimum, as an oncologist, I want to give a drug where my patient still can maintain at least, number one, the basic activities of daily living. That means your toileting, your caring for yourself, changing or having a bath and all, and some instrumental activities. That means things like using the phone or being able to walk, go and buy your own things. So that level of independence is something that I hope to preserve even while giving chemo. So if my patient says, I can't do all these things now, doctor, I'm bedridden because of the chemo, I'll say, stop, no point. Why kill the cancer and then kill yourself in the process? There's no value. There's only value in killing the cancer cells if you can also have a good quality of life and prolong it. Right? So that's one thing. And a lot of patients think it's worse than dying. So this, to some extent, may be a misconception, especially with the newer drugs. And finally, the goal of treatment. This is something very early on your doctor will discuss with you. They had a study where we showed that this was amongst cancer patients with stage 4 disease, and they interviewed them, and they found that 75% of them actually thought they were going to get cured, right? But stage 4, there's no chance of cure. Why did they think that? Sometimes, unfortunately, oncologists, myself included, in the process of trying to give the patient hope, we may have given a bit of false hope, right? So that's where, by all of you attending talks like this, you know where you stand, what is the reality, so that sometimes when you go and see doctors, because we also find it difficult in telling you that there's no hope and kill your hope, and a lot of times families are very cautious. They fear that their elderly parents, once they hear stage 4 cancer, straight away they will die from the news, right? From heartbreak. But the heart won't break. The heart can get attacked, right? You can get a heart attack or from a shock of it, but it happens very rarely. But people are very protective of their loved ones. So at the end of the day, some of you who have cancers yourself may not have got the right information and may carry on false hope. So coming to events like this may give you a better perspective of what's really happening. What I meant by not very efficacious is these chemotherapies are not going to cure. They're going to buy you time, and we hope they buy you good quality time, but they will not cure you. So that 75% of patients who thought they were going to get cured all had misconception. But the same 75% said they actually love their oncologists because the oncologists give them hope. While the 25% of the oncologists who told them the truth all didn't like the oncologists. Because nobody wants to hear bad news. And this was a very large study published at Harvard, right? So I always grapple with that. What do I tell my patients? Should I tell them the truth? If I tell them the truth, they'll say this oncologist is lousy. Go and say this kind of nonsense. I better go see Chinese sensei. Chinese sensei can cure everything. No way. Which is not true, right? But at least they won't tell you you'll surely die. They'll somehow play the middle ground. So that is one of those skills I probably have to learn from them. But anyway, how do I convince my patients? So one way is to use evidence. The evidence, we hope, doesn't lie, because these are large studies, clinical trials and all that. Companies spend billions of dollars. So they do it very rigorously, scientifically done. And then I will go through the side effects in detail. And this is where patients get scared. But I think it's better you hear it from the doctor than read the product insert. Every time there's a drug, when you buy your drugs from the pharmacy, there's a product insert. Wow, if you read that, you'll never take any medicine in the world. Because all the side effects in the world they put there. Why? Because the company doesn't want to get sued. Because if you have a side effect and they didn't inform you, then they are liable. But the reality of the fact is you don't know the percentages. There may be something like maybe one side effect is diarrhea, but only 1 in 10,000 of the patients who take it get diarrhea. But they still have to put diarrhea there. So what you need to do is talk to your physician, your doctor, and ask them, but what is the percentage? What are the chances of me getting this or that? And when you hear the numbers, you'll say, actually it's reasonable. If it's only 5%, then 95% I won't get, right? So you always hope you are not the 5%, but sometimes bad luck, you may be the 5%. But at least you know, based on those kind of numbers, you can then make a more informed decision. Then you balance, again it's that balance, pros and cons. So if side effects are this much, but the benefit is this much, right? And this is where your physician will have to decide for you in terms of providing that balanced numbers. So if the benefit is more than side effect, then perhaps you should do it, So a lot of this is not really guesswork now. We know a lot of the data. We know the side effects well. We know the benefit well. We can provide you this information. So ask your oncologist these things. Now, the other thing is maybe try a cycle. The oncologist will say this chemo needs 6 cycles, or this oral medication you need to use for long term. So try one cycle first. If there's no trouble, then carry on, right? So that is one way to help you decide whether to continue on the treatment. Don't make the decision based on the fact that somebody told you or you know the side effects are a lot, but it may not apply to you until you try it. So that's one way. And the other thing is come for your follow-ups regularly. Do not miss follow-up. Once you're on medication, you need to be reviewed because these drugs affect all your organs. So if you don't do regular blood tests or come for follow-up and hope to just continue treatment, then you run into trouble as well. And finally, the right dose for the right patient, right? Is personalizing it. When you're older, I would dose reduce. A lot of our chemo, actually all our chemo go by weight and height. So bigger size patients will get more chemo, smaller size will get less chemo, right? And we have other tools also to predict chemo toxicity or side effects. Now, I'm bringing this up because in prostate cancer, we also have hormonal drugs. If you compare hormonal drugs versus chemo, hormonal drugs generally have a lot less side effects, right? So patients will think, why not I try the hormone first? And then chemo we keep to the end. There are some problems with that. Because chemo, we can only give when you're fit. If let's say we start with the hormone first, when you are actually a suitable chemo candidate, but you start with the hormone first, and it doesn't work. How we know? 2 months later, we do a scan, the cancer is growing. But when the cancer grows, you get weaker as well. Now you're weaker than 2 months ago. Are you fit enough for chemo at this point? Probably not. So you may have missed the boat. So it's important not just to choose the right treatment, it's important to choose the right treatment at the right time. And so at that time when the doctor presents all these things, then you must ask the doctor, what is the right treatment for this point in time? Now, hormone-sensitive prostate cancer, if you have aggressive cancer, you should get chemo. So the doctor will tell you, actually, you should get chemo. But there's also all these hormones. So you ask the doctor list for you in terms of benefit, which would be the best. Then choose that, because if you miss the boat, then later on you're weaker because cancer has grown or progressed, then you may not be able to use it. See, at the end of the day, all these drugs won't cure, but they'll buy you time. So it's like fighting a battle. You have maybe 5 approved drugs that we can use in advanced prostate cancer. You want to maximize your life, you should try to use each one of them. But if let's say you get too weak to use some of them, then you only have 3 drugs, right? So you may not have as many weapons. At the end, like I said, it's a war, right? It's a battle. So what has changed now is that there are new tests available, not yet here, but people are still doing trials. This particular test just got approved by FDA a few weeks ago in the US. So this is actually a blood test. All right, sorry, just want to show you the blood test. So I'll go back to the results. They take your blood, and then they look for this thing called ARV7. Right? If you have ARV7, your response to the hormone is 0%. So instead of just trying luck, you use the hormones and then see how, we actually know who will benefit and who will not benefit. if you have ARV7 positive, then you shouldn't get the hormonal drugs because you won't benefit. Zero response. None, but it's a very small study, only 60 patients. But John Hopkins have got their test approved. That's where this study was done. We are doing it on a research basis in Singapore. So even if you want, I can't do it for you as a commercial thing. It's not like you pay, you can do that. But if you want it to go to US, they can do for you if you pay. So what does it do? It saves you the time because then you don't use hormonal drugs, and it saves you the money. I don't know how much abiraterone or enzalutamide costs here, but in Singapore, 1 month of either one of the drugs is 5,000 Singapore dollars. So multiply by, yesterday I changed money, 2.9. So it's nearly 14,000 ringgit 1 month. So some of you may be fortunate if you're government servants, then it's covered. But otherwise, you have to pay for the cost, so it's very expensive. So if you have these tests available in the future, it shows you're positive, then you don't waste. Normally we give patients for 2 months at least to see response. So you'll save $28,000. This test, I estimate when we actually roll it out as a commercial kit, will cost about maybe 1,000 ringgit. So 28,000 ringgit versus 1,000 ringgit is the savings. So that's the future. So this is to show you that if you have ARV7 positive, you have very poor response. This red line here. Your ARV7 negative, you have good response. So, but how about chemo? Chemo, it doesn't matter. ARV7 positive or negative, you still respond. Right? So those patients who are positive should actually go on and get chemo. And some patients, after using chemo, they may become ARV7 negative. So which means they can actually use the hormonal drug after that, even though originally they may not be able to use it. So chemo may help reverse that. So chemo, there's a role, but for who do we give chemo to? Generally, patients who have cancer that has spread to important organs like liver and all that. Those who don't respond to hormone for very long, the injection that you get, or some people have occipectomy, they remove the testes, then they may respond better to chemo. Those high Gleason grade, very aggressive cancers, and those who have symptoms, mainly because these symptoms correlate with amount of disease. The more disease, the more symptoms they have in general. So these studies actually show that those who respond to hormone very long, more than 16 months, they actually respond to they respond to hormonal therapies quite well. So if your injection, you're on it for many months, you responded for more than a year, most of the time more than a year, don't need to be 16 months. Then if you take the oral hormonal tablet, it works well. That's what this means. Well, this one shows that if it's for chemotherapy, it works well regardless of whether you respond for very short duration or long duration. That one, hormonal therapy, if your injection doesn't last long, your response to the hormonal is very poor. So how long you last on that injection or the removal of the testes actually makes a difference in helping you choose. These are other ways to help you choose, because now we don't have the blood test available. So we got to look for clues of what to do. So this slide is just to explain to you that what you choose first will affect the response of the second drug. So if you choose chemo first, then the hormone may not work so well. And if you choose hormone first, then the chemo may not work so well, because there's some overlap in the way they work. Yeah, so that's why if you're resistant to chemo, then later on the hormonal tablet won't work as well as if you gave hormonal upfront. That's why it's important to select the right drug at the right time. So how we choose in general, if you have very short response to the hormone, or your Gleason score is very high, or your testosterone at the start is very low, very high actually, or visceral mets means those that have spread to the organs, then if the answer is yes to these questions, then you can actually use a hormonal therapy. You respond very poorly to hormonal, you should get chemo. This is the red line here for chemo. But if the response is low, you have a long response to ADT, or your Gleason grade is low, not that high, not 8, 9, 10, like as mentioned by Mr. Murali just now, he showed you the aggressiveness, then you can use hormone. So this is a method we use now because we don't have the blood test available to decide who should get or who shouldn't get chemo. So I think all this information your doctor will provide you, and then of course the decision will be left to you at the end of the day. But don't go about it in an emotional way, because chemo, you think you're going to lose hair, very terrible and all, then you decide on the hormone, because you may miss the boat. of using one useful drug. But I'm biased because I'm a chemo doctor. So everything I say, I'll say chemo, chemo, very good. So you must take that into account. So that's why I'm glad that all of you all have taken time here to come and educate yourself. Because the best way actually to get the best treatment for you is you need to take charge. If you find the information overwhelming, many of you, your children are probably very, very well educated. You can ask them to help you with the decision, right? They can help simplify things as well. But you need to be able to take charge because there's just so many variables, different doctors, different institutions, a lot of opinions, but you want to choose what's best based on evidence. Now, in real world practice, right, whatever I said actually all boils down to this, right? Because I told you how much this hormonal treatment costs, right? They're all like, more than 10,000 ringgit. Then chemo also is not very cheap, right? So at the end it boils down to money. So when it comes to money, then you again another decision. Is it cost effective? Okay, let's say the treatment costs 10,000 a month and you need to use it for 1 year. That's 120,000. But if the studies only show that the benefit of the drug is an extra 4 months of survival, then you think carefully. Should I pay 120,000 to live that extra 3 or 4 months? Or should I save the money and give to my children or grandchildren and as a legacy? This is a question realistic question people have to think about. In general, I think patients themselves are very often very rational, but families are not. They don't want to see you go. 1 day extra, so they'll pay as much money as they can, right? So, but you have to sometimes rationalize with them because there's no cure. These things will buy time. Is it time you can afford to buy? And at what cost, right? Because you spend the money, that money have gone to help your children or their future. In Singapore, sometimes people sell their flat, their houses, their cars and all to pay for cancer drugs. And they're left with nothing. And if they get it at a very early stage and they have young children, they may jeopardize their children's future sometimes. So that's why it's important to get the right information. Is my cancer curable? Yes, then okay, no problem, you carry on because whatever it is, you can get cured. But if my cancer is not curable, this drug, how much time can it buy me? The doctor can tell you. Of course, they'll say, few months depends this But tell me the clinical trial results, how many months? And then you can make that decision. Okay, so I'm going to spend this much of money for 1 month extra survival. Will it be good quality survival? We can't predict, right? There are side effects. So there are a lot of things to decide. Unfortunately, that is life and that's the reality of the situation. In countries like US or Europe, where it's nationalized healthcare, you pay 50% tax, but the government take care of everything. Then it's different. Then they'll just give medication one after the other. But here, this is a major factor. So I want you to consider carefully. Sometimes I feel bad offering an expensive treatment because I know the patient cannot afford, but their family will feel bad also because they can't afford, but the treatment is there. But I always tell them, this is not going to cure you. It's going to add a few months of life. Don't worry if you can't have it. Important is to focus on your quality of life. That's the important thing. Is it that limited days you have left, can you spend with your family? Can you be pain-free? Can you not have symptoms? That is more important than simply taking all these drugs and then living extra 3 months, but the 3 months in the hospital because side effects. Right? No point, right? So got to balance that properly. Also, it doesn't mean go TCM. TCM also can send you to hospital. The best is if you don't do anything, just don't do anything. Go to palliative care medicine. The doctors will treat your symptoms. Better spend money on those things. Don't go TCM or some new medication, somebody Sabah snake grass, $1,000. They squeeze into one juice and all that. So what's new? These are some new things. So last year they discovered there's a new histological entity. And I think pathologists are still learning about it. The paper hasn't been published yet. But this shows that some cancers are more aggressive. Last time we didn't think it was so aggressive. But now this IAC, intermediate atypical carcinoma, they actually they perform like small cell cancer. They're very aggressive. So by discovering new things, we'll know how to predict your survival better, right? Now, this is the latest thing. I hope I'm not running out of time. This is the latest thing, which is the future. In the future, what people are going to do is they'll take your blood and they'll get those cancer cells. Remember earlier, Mr. Murali showed the picture how cancer cells can escape into the blood. The ARV7 is like that. We capture those cancer cells and then we put them through a machine that tells us what are the mutations. And then what result will come out, And in the future, we'll have a list of drugs and we can personalize it. We can say you have this mutation, okay, we give you this drug. Now we don't have this. So we don't know how your prostate cancer is different from the other person's prostate cancer. We know they are different, but we don't know how. So in the future, we'll be doing this. We'll do sequencing or genetic tests for the tumor and also for the blood. So these are some tests done in America using that method, and they found that nearly 100% of prostate cancers all have mutations. But we don't have drugs to tackle all the mutations. In the future, when we start developing more drugs, then maybe we can actually treat everyone. Maybe there may be a cure, we don't know. So this is an example of one of those drugs. BRCA is actually seen in females with breast cancer, like Angelina Jolie and all that. But the males in that family can get prostate cancer. And if they get prostate cancer, we have a good drug that can target that, that can really prolong their life. So this is all new development. So some patients, some of you may know if your relative or your sister or aunt has the BRCA gene, then you may want to go and get genetic screening and see whether you have, then you may be eligible for some of these drugs. So in summary, there are a lot of treatment options. You need to see how much benefit it will give you. It's not going to cure you, but it can buy you good quality time. And we can use some factors, like I mentioned it earlier, to choose those treatments. ARV7 is one of them. In the future, it's going to be that. We're going to start doing genetic tests on your tumor to find what are the troublesome mutations that we can treat. So finally, this is from one prostate cancer survival group. The treatment also goes by the same concept. We are trying to outlast and outlive it. But with advanced prostate cancer, it will catch up with you. But how long you can outlast and outlive is something we can't predict. So you should still try if it's within your means, and hope your oncologists, and I'm sure your urologists and oncologists will work together with you in trying to achieve that. So it's good quality life, not just long life.